Thank you so much, everyone. It's so great to see everybody. This is Raji Kapolu, current president of NAPNAP, and I'm so happy that we were able to host this town hall this evening to focus our discussion and time to reflect a little bit on the impact of COVID-19 and what we've learned so far and what we can share with one another. So I thank all of you. We had over 200 people register for this town hall, which is amazing. And so I'm so pleased that we can leverage this technology to connect us. But again, like I said, have an opportunity to just stop and reflect and think about some of the direct and indirect impacts that we felt of COVID-19 on our practice and in caring for children. So a huge thank you to Michelle and the National Office staff for helping bring this together. I wanted to share just a few reminders and a couple announcements, and then we'll go ahead and get started. Again, everyone is muted right now for the time being, and when we're ready to open it up for questions, there'll be a point where we'll be able to unmute folks. But definitely feel free to take advantage of the chat box. It's the best way to type a question or say that there's something you'd like to respond to. When we get to the open Q&A, I'll try and make sure I call on individuals and we'll get to everybody one by one as much as we can. We'll try and limit everyone's responses to about a minute or two so that we can have everyone have a chance to speak. And I do want to let everybody know that the town hall will be recorded or is being recorded this evening because we're hoping to have it be an on-demand option for members to view later if they weren't able to attend this evening. So thank you again for being here. I also want the group to know that tonight's town hall is supported by a grant from Pfizer Incorporated, which is important to know. And a couple quick announcements. The first is it was very important for me to have this town hall, but I also wanted to make sure our members knew about some of the other resources that we've put together to support our understanding and our knowledge of everything that's happening with COVID-19. So I hope all of you are aware of our coronavirus safety page, which you can get to very directly from our website, which has a lot of great evidence-based resources and some high quality resources for our members on caring for children, as well as some of the evidence and science and the data that we have right now. We hosted 4 Facebook live stream events, which I'm sure many of you had a chance to attend, looking at topics on telehealth and provider resilience, mental health care of children, as well as caring for children at home. And so I thank our speakers for being a part of that, and you can go to our Facebook page to reference that. We, of course, have our town hall this evening. We also recently released 3 official statements related to COVID-19 around immunizations, around age parameters, as well as how we can help foster health and well-being in children from a healthcare provider standpoint and also from a child health standpoint. And probably one of the most exciting things coming up that I know many of you are aware of is our virtual conference on pediatric healthcare. And that's going to be June 4th and 5th. Hopefully all of you have already registered. And if you haven't, early bird ends at the end of the week on May 15th. We are so excited about this platform. We're so disappointed that we couldn't meet together in Long Beach for our national conference, but our conference planning committee, our national office staff have come together to work on this virtual platform. There are tracks in acute care, primary care, and specialty care. And what's great about this virtual platform is that you can not only attend the sessions, but there's also a networking lounge where you can talk with one another. And there's a virtual exhibit hall as well. So some really neat ways to leverage the technology. And you can access the sessions through this virtual conference for 90 days after the meeting. So there's lots of opportunities to go back in. And if you're a real go-getter, you can earn 36 and a half hours of continuing education if you took every course that's available. So we really are so proud to offer this to members, not only for the continuing education, for the virtual experience, but also to honor those presenters who were able to put their presentations together that couldn't present in Long Beach. And then the last thing is probably one of the most important things I think we can do right now is support each other and support NAPNAP. We are so committed to growing our membership and the diversity of our members. And so the Connect and Recruit campaign is going on right now until the end of the month. And so you can save up to $80 when you refer a colleague, a student to NAPNAP to become a member. So if you go to napnap.org/connect-recruit, you can get some more information on that, and we look forward to continuing to grow our membership and diversify pediatric advanced practice providers. So Thank you again so much for joining us this evening. What we're going to do in terms of the town hall is first I'm going to call on a few speakers that are here this evening to share their perspective of working through COVID in a primary care setting, in an acute care setting, and also from a policy standpoint. And after we hear from each of them, we're then going to open it up to the pre-sent in questions, and there were fantastic questions, and so we'll pick out a few that were sent in and have some good dialogue and conversation on that, and then we'll open it up to the group to see what other questions or comments will be there. So starting with our first speaker, we're going to start with a primary care overview, and I'm going to invite Mary Gallagher to speak. Mary is a primary care nurse practitioner at a federally qualified health center in Los Angeles, California, an area that certainly is very impacted by COVID-19. She completed her Bachelor of Science in Human Development and a Master of Public Health at UC Davis, and she completed her Master of Science in Nursing at Yale School of Nursing, and she is a member of NAPNAP's Conference Planning Committee. So Mary, if you are ready, we'd love to hear your perspective from a primary care standpoint of how it's been for you in the Los Angeles area.
Sure. So yeah, I just want to provide some context, I think that might be helpful. So Los Angeles County is home to 10 million people. And as of today, we've had 34,000 cases and about 1,100 of those have been pediatric patients. So that just that gives our sort of burden of disease. We've been lucky to have pretty decent countywide testing capability. So actually right now, any symptomatic patient who wants a COVID test can get it at a county facility or county testing site. And then any asymptomatic person with a risk factor, for example, those over the age of 65, anyone with chronic medical condition, certainly any essential workers can also get tested. So I think it's been really nice. You do have to make an appointment though, which can be challenging, right, for some of our patients. Most of the appointments are made online. There are telephone, there's a way to call 211 and make an appointment, but we have had to help some patients make appointments. And then there's always the concern about how you get to a drive-through site if you don't have a vehicle or there's not one in your neighborhood. So we've had to overcome some of those challenges, but just wanted to give you some context of what's happening countywide in Los Angeles. In terms of what's happening in my practice, as has been documented well, by NAPNAP, by a lot of our members, by the AAP, certainly our volume has decreased substantially. We're probably down 30 to 50% depending on the day, and we have had some people voluntary furlough in the last couple of weeks. Overnight, we've changed, from doing zero telemedicine to doing probably 80% of our visits telemedicine. Most of those are on the phone right now, and we're beginning to roll out video capability. In clinic, we've really limited the amount of patients that were in families that we're seeing in clinic, both for their safety and obviously the safety of our staff. Right now, we're seeing well child visits under the age of 2. Definitely, anyone who calls needed vaccine catch-up we're seeing. And then in teenagers, we're seeing actually quite a few pregnancy tests, and then any birth control that needs an in-office visit, for example, Depo, IUD insertions, Nexplanon, we're seeing those. All of our sick visits are triaged to the telephone first, and then depending on how the patients are presenting, we'll either do close follow-up over telephone or we'll bring them in. In terms of preventing, spread, when patients come in, we've done a lot of environmental controls to help limit spread of COVID. All of our staff and patients are screened by temperature and by brief history when they enter the building, and that's every day. Every day you come into the building, the staff are screened. We also require masks for all of our staff and all of our visitors over the age of 2. And we've limited the number of people that can accompany patients. So for example, right, we're all used to having mom with her 4 children in the building. Now we can only have 1 caregiver. And then we've also separated sick rooms and well rooms. And then we're not seeing very many patients in clinic, but we're doing a good job of staggering those visits. So to avoid any, overlap of patients in the hallway or overlap of patients in the waiting room. I know some other practices have separate entrances. We have not done that yet. That might be something that we're going to think about going forward though, because we have to think creatively, to get people back, certain groups of patients back into the clinic for certain appointments that we're not seeing right now. And so I think we will address that in the future. And then in terms of how we're handling anyone with COVID symptoms, we have a tent out front. So anyone who wants a COVID test or who presents with COVID symptoms or screens positive, even though they're coming in for a non-COVID related visit, they're all sent to a triage tent out front. So we're not letting anyone with COVID symptoms in the building necessarily right now. And we are doing some COVID testing ourselves. We're trying to prevent exposure, to our staff. So we are trying to encourage most folks to go to an LA County testing site, but like I said, there's transportation problems. Some people are just more comfortable coming to a site that they know. And then, the last thing I guess we've done is we do have an RN monitoring program. So anyone who does have COVID symptoms who's high risk, they are getting daily phone call check-ins from one of our RNs. So I think that's been nice for families. And that's that's overview of what we've been doing in terms of long term. What I think this will how this will change our practice going forward. I mean, I certainly think that telemedicine is going to play a huge role in our practice going forward. We were doing none of it before, and now we're, like I said, doing quite a bit. And I think it's, families have actually we've gotten a lot of positive feedback about it. So, hopefully that's something we can continue. It wasn't covered by our payers before and now is temporarily covered. So hopefully that'll be a long-term thing. And then certainly, we've seen lots of states change or hopefully there'll also be a pathway to more independent practice for NPs. We've seen a lot of states sort of change the restrictions recently. So hopefully that'll be a long-term thing. And I think also we're going to need to continue to be creative in how we engage with our families, right? People are still, even as the restrictions on our community activities are lifted, I think there's still going to be fear, and we're going to have to think of creative ways to engage with them, especially as I think we've all seen the CDC data recently with huge drops in vaccines. So I think we're going to have to really think about how we're going to engage those families again. I think there's some positive things that are come out of this. Certainly in terms of NP practice, I think telemedicine, but again, I think that it's going to take some time to recover and getting people engaged again, coming in person. I think that's all I have. If there's any questions right now or questions later.
That's wonderful, Mary. Thank you. No, that was so helpful. I think just to understand how it's impacted you locally in your practice, how you're trying to restructure the environment to make families feel safe, and highlighting some of the opportunities that will hopefully be a positive outcome from this whole experience. So I think we have a couple questions coming up, but I'm going to keep us moving, and then we'll make sure we have a chance to answer them when we open things up. So thank you. So I also wanted to make sure we had a little bit of a perspective from an acute care standpoint. And so we're going to invite Pat Chavarro next. Pat is a pediatric nurse practitioner at the Institute of Reconstructive Surgery, Plastic Surgery at NYU Langone Medical Center. And for the past 25 years, she's been the PNP on the cleft lip and palate and craniofacial teams at the Institute, caring for children 0 to 21 years of age. She certainly serves as an important liaison between the patient and family and their healthcare team. And Pat has published and lectured nationally and internationally regarding the comprehensive care of these very special children. And I've had the opportunity to be on Pat's radio show, which was a fantastic experience. And we're so happy to have her this evening to share a little bit of her experience from an acute care standpoint, and certainly being in New York City, which we know is deeply impacted by this pandemic. So Pat, thank you so much for being here.
Thanks, everyone. Can you hear me?
I can.
So I sort of have a unique position because I work both inpatient and outpatient. And so I feel like I have a pretty good big picture perspective on a lot of the issues that we as PNPs face. And as you know, we're in the epicenter of the epicenter in this country. And as of yesterday, I didn't check the numbers for today, we've lost over 21,000 human beings to this. And what's been extremely interesting to me is I have been so grateful that I have found that the pediatric population has not been affected greatly by this, because I think, as we all know, if children had been affected to the same extent as adults, we would not even be looking at how to get back into the reality of the opening up. That would not be happening. And so I'm so grateful for that, except what's extremely interesting is that now at the tail end of this, and we're now on, we've gotten to the peak and we're starting to go down, is that now we're seeing this new issue, which is very, very important for pediatrics, and I'm sure you all know this, is about this new inflammatory disease that's associated with kids with who are COVID positive, with Kawasaki. And so that is, I think, what we are starting to deal with on the inpatient side. We were not seeing that, and in fact, and for anyone that works in a children's hospital, we have found around the country that, and in NYU for sure, we had very, very few pediatric patients. And what happened in New York, and I don't know about other states, is that they decided that they would up our privileges, and I was not totally happy with this, to the age of 32. So for everybody listening, do you feel comfortable being 100% managing a 32-year-old patient? And so that was one of the things that we were sort of grappling with in New York, except that what happened is we had very, very few pediatric patients. And so we ended up, NYU became a COVID hospital, and many, many hospitals in the country. And I wanted to reference that in the Journal of Pediatrics, if anyone has read online, that my colleague, Tanya Sheminsky-Marr, is one of the authors of a paper at Montefiore, which got the hardest hit. The Bronx got the hardest hit of the entire city of New York and the entire state. They wrote a paper about how they literally transformed their pediatric hospital into an adult COVID hospital. It was incredible. And it just came out, just got published. It's online. I would highly recommend you reading that. But so, that was where sort of all the focus was shifted. They got everyone up on, all the pediatric nurses on caring for adult patients, because at one point there were almost no pediatric patients at Montefiore and at NYU as well. So I think a lot of our focus was not on caring for children with COVID. So right now, what we're dealing with are a couple of things. One, we have kids now that are coming in, and in New York, and I don't know, and I'd love to hear what's going on in the rest of the country. As of yesterday, there were 100 kids in New York State with Kawasaki-like illness who are COVID positive. And in New York, I think we lost 5 children. 5 children died. Yes, I think that was in the last couple of days. And so this is a thing, I think, on an inpatient acute care setting that we are starting to look at. And I think in terms of when I look at the big picture, because I always associate what's going on inpatient with outpatient, is if you have patients that have any of these symptoms, you need to really start looking at that very, very closely, very carefully, get those kids tested. So that's one thing I wanted to highlight. I think the other thing that I have found is we, in plastic surgery, we stopped doing surgeries our last day of surgeries was March 20th. And that was actually the day that I was exposed to COVID. I don't know if some people know that I actually got COVID. I got the virus. So luckily, I'm very grateful I had a mild case. So what happened to me was I was unable to work on the front line. What I ended up doing was, once I was well, I was calling back the virtual urgent care patients and emergency department patients who came through NYU, thousands and thousands of patients. So I helped the nurses and NPs call back those patients to see how they were doing, because many of them were not being tested. Because in New York, the testing was so limited at first that they were only testing very symptomatic people coming through that would have to be admitted. So we were sending patients home, not tested, who had symptoms, but their O2 levels were okay, they were breathing okay. So it was a really, really difficult time in New York. The one thing I'm seeing now, and I'm reaching out to all the primary care people, is that we are now back doing surgeries. So every child has to be COVID tested. That's fine. What I'm finding is many of my pediatric craniofacial patients are not up to date on their immunizations because they're afraid to go get them. So I would love to know what's going on in primary care about that, because I am very nervous about this, that I find a huge, I would say 50% of my patients are not immunized. And I'm saying to them, you need to go to the PCP. I want you to get up to date on your immunizations. The last thing we need are other issues related to not being immunized. That's one thing. Yeah, and I don't know how much more time I have, Raji, but I wanted to say one other thing. So when I did my radio show today, I have a show called the Nurse Practitioner Show on Dr. Radio. I love anyone who wants to be on my show, by the way. But one of the things that we talked about today was I had a physician who's a pediatric medical toxicologist, and talked about the huge increase in calls to the Poison Control Center on pediatric patients who are being exposed to poisons and chemicals in their home because of all the disinfecting that everyone is doing. So, just a shout out about that, looking at that. So I'm sure I went over my time. I always do. So I'm going to stop talking now.
No, that's okay, Pat. Thank you. Thank you. Thanks for sharing the perspective. We did get many questions, of course, about this inflammatory response that we're seeing in children. I think we're learning a lot more about, so we can talk about that some more.
Sure.
As well as the impact you've seen. And I think many others are probably experiencing what you are in terms of bringing back elective cases and how that's playing out. And thank you for sharing your COVID story yourself. And we're so glad that you're healthy and okay.
Thank you.
So. Okay, I wanted to have a moment also for us to share a little bit about NAPNAP's response when it comes to policy, because we are on the front lines doing what we can in our clinical practices. But of course, NAPNAP has a huge role in having a voice from a federal standpoint about advocacy as it relates to PPE, as it relates to access to care, as it relates to ensuring that children have the benefits that they need at a time like this. And also addressing some of the unique needs that we know children are facing. So I, of course, want to call on our health policy expert, Dave Mason. Many of you know him very well as a veteran working in federal health policy circles for more than 25 years. He's represented NAPNAP so wonderfully for the last 10 years, as well as working with several other national nursing organizations, including the National League for Nursing and the National Organization for Nurse Practitioner Faculties. He is a former congressional press secretary and legislative aide, and has also directed legislative and regulatory policy and political action for the College of American Pathologists and the American Physical Therapy Association. So we're so grateful to have his experience, I'm sure. And we know from a policy standpoint, this is unlike any other time that we've experienced. So I wanted to give Dave some time to share at a high level some of the things that we've responded to and opportunities for us going forward.
Great, thanks very much, Raji. Am I coming through okay?
Yep.
Great. Well, it is an honor to be with you. It's always an honor to talk to you guys about policy and the work that you're doing. But I think particularly during this pandemic, it is a great honor to represent the nursing profession and particularly to be working with NAPNAP. Just as I know you're facing challenges at your level and dealing with a lot of policy issues at your level, these are really strange and challenging times in the federal policy environment as well. We have been working, obviously, as Congress has been dealing with all of the various legislation going forward, $3 trillion in 4 different bills. And a number of provisions that nursing groups have been working on for years that have been part of this effort. But I think the truth of the matter is that we're in a transition period now, and you're dealing with it as well, where the impact on the economy is weighing almost as heavily as the impact on public health. And I am afraid that on its best days, the federal policy effort lagged behind what you were facing in the clinics and on the front lines. And my fear is now we're looking at even greater delays as folks begin to debate competing policies and competing priorities, and essentially are a little sticker shocked by the amount of money that the federal government has already allocated to fight this pandemic. But on that note, I want to obviously give you the latest information that we have available, which, as you've heard by now, House Democrats earlier released the what they're referring to as the Health Economic Recovery Omnibus Emergency Solutions Act, which is known as the HEROES Act, HR 6800. That in itself is a $3 trillion stimulus relief package that combines additional relief to state and local governments with direct cash payments to individuals, expanded unemployment insurance coverage, food stamp funds, as well as extraneous kind of issues like funds for voting by mail and trying to bail out the postal service. And as I say, it comes with Congress already having spent $3 trillion on 4 different measures. The House is scheduled to vote on the HEROES Act on Friday, but frankly, that could change. It wouldn't surprise me at all if it does. Republicans are clearly going to vote against the bill, and progressive Democrats are also unhappy with it, may oppose it, because it doesn't go as far in some areas as they wanted it to. And that disagreement between the two sides may force Speaker Pelosi to delay the vote. One way or another, assuming the bill makes it through the House, there's no chance at all that it will be considered by the Republican majority in the Senate, at least as it's written currently. So this really serves as the starting point, House Democrats' starting point, for eventual negotiations between the Senate and the White House. But those talks have not started yet, and it's very unclear when they will. Senate Majority Leader Mitch McConnell said yesterday that Republicans are still assessing what we've already done while raising concerns about the federal debt and focusing on designing some liability protections for businesses as states look to reopen their economies in the coming weeks. And that idea is something that many House Democrats don't support, and it is clearly not addressed in the HEROES Act. So this legislation isn't focused on healthcare providers nearly as much as the Coronavirus Aid, Relief, and Economic Security, or CARES Act was. That bill reauthorized funding for nursing workforce development programs, authorized nurse practitioners and clinical nurse specialists to certify home health services for Medicare patients. And also the bill that we're about to consider on Friday will address some issues that NAPNAP and other organizations have been raising, provides $200 billion to fund what it describes as hazard pay for essential workers who've had to risk exposure to the virus as they've stayed on the job. That goes well beyond healthcare providers only, but does include nurses and healthcare providers. And then just real quickly, key provisions of the bill: almost $1 trillion in aid for state and local governments, as well as $1,200 cash payments to individuals and $1,200 for dependent children, so up to $6,000 per household. It would also extend a $600 weekly increase to unemployment insurance through January, and provides another $75 billion for virus testing and contact tracing. So issues that are important in addressing the pandemic. Among the things that NAPNAP has been working with other organizations to push forward, the bill would increase federal matching payments to state Medicaid programs by a total of 14% through June of next year. It blocks HHS from finalizing regulations that would limit state options for financing their state Medicaid services. And it also temporarily increases Medicaid payments to disproportionate share hospitals by 2.5%. There is also $10 billion in additional support for the Supplemental Nutrition Assistance Program, $1.1 billion for the Special Supplemental Nutrition Program for women, infants, and children, and $3 billion in emergency relief for school meal providers. It also provides $100 billion through the Public Health and Social Services Emergency Fund for grants to hospitals and providers to reimburse for expenses or lost revenue that is attributed to the public health emergency. So a lot of issues that we have worked on there. As I say, it isn't going anywhere on its own, but is a reasonable starting point for some negotiations that I hope will begin sooner rather than later, although it's really not clear how quickly we'll be getting into those things. It also fails to address a number of issues. Mary mentioned in her discussion the new CDC information on the decline in vaccinations. I was in a meeting earlier today where there was a great deal of concern about that, and the fact that the bill is silent on it, that there are no provisions attempting to address that issue. So as the negotiations go forward, I think there will be opportunities to deal with other issues that we think are important. And then I wanted to wrap up. I think you're probably mostly familiar with this and probably have been dealing with them on the state level. But along with what Congress has been doing, the Trump administration and the Department of Health and Human Services have taken a series of steps to temporarily list a host of barriers to APRN practices. And just very briefly, in mid-March, HHS significantly expanded Medicare telehealth services and payment, including removing barriers to APRNs providing those services. At the end of March, HHS authorized hospitals to use APRNs to the fullest extent possible, including ordering tests and medications that may previously have required physician certification or supervision. In early April, the agency allowed NPs to conduct medical exams for Medicare patients in skilled nursing facilities. And then at the end of April, CMS issued new policies authorizing NPs and clinical nurse specialists to order home health services, establish plans of care, and recertify eligibility for home health care for both Medicare and Medicaid patients. And also continue to broaden the expansion of telehealth services to include audio-only telephonic behavioral health and patient education services and evaluations. As we've said frequently in some of our other conversations, most of these changes are temporary for the duration of the public health emergency. So what happens after the emergency is declared over is really unclear. It would seem to be very difficult to roll back all of the policy changes, although there will certainly be some pressures to reimpose some restrictions and some oversight requirements. But I think in all of the nursing community's discussions really underscores the need for practices to be collecting data on the impact of the temporary policies and to be able to provide evidence to convince policymakers down the road that permanently eliminating these practice limits makes a lot of policy and public health sense. So I think with that, I will stop and see if folks have questions.
Thank you, Dave. Thank you so much. Clearly a multidisciplinary way for us to approach this and continue to find ways to advocate for the spaces that we feel most benefit children. But to your point, to make sure that we use this as an opportunity to collect the data on how we have been able to improve access to care in a number of ways with some of these loosened restrictions. So thank you for that summary. Well, what I'd like to do now is open this up, and I'd like to start with some of the questions that were pre-submitted just to make sure we get through some of those, and then we can open it up to the group. And I do see some of the questions coming through in our chat, so we'll do our best to get through them as well. So I thought first we'd start with some of the questions that came through regarding primary care practices, and I think we've already started to talk about them. First and foremost, several questions about what can we do as providers to have families come in for their routine immunizations. And I will reference our immunization official statement that came out recently that discusses this to our members because we certainly, as we said, certainly don't want to see any indirect or another infectious disease outbreak of any kind that can be prevented with immunizations that we can provide. So I think I'll open this up if either Mary or Cheryl Cairns, who I know has expressed interest in
Cheryl, thank you.
Thank you, Cheryl. Yes, please go ahead.
Okay, and so no, thank you for allowing me to participate tonight. And I thought the conversations earlier about ways to get children in, I thought were great. Just recognizing that if you look at the literature that's currently coming out from the CDC and many organizations, they really are starting to see a significant decrease in immunizations and vaccinations in our offices with our children. If you look at measles, they actually did see a decrease realistically after that first week. So again, very significant decrease in getting vaccines. So some of the things that we worked on and talked about is scheduling separate well visits and sick visit hours during the day to avoid exposure. And I think one of the big things that we need to address is really being able to reach out to the parents and talk to them and telling them how, you know, your site is safe and what you are doing to keep your site safe so that you can keep their children safe. Again, and then staggering appointment time so people are not clustered together in common areas. If there's a way that you can bring children in, kind of having somebody that's screening at the door and then somebody else may be going to get them and bringing them right back into an exam room so they're not waiting in a waiting area. Allowing people to wait in their cars until the exam room is ready and having them text or call into the office. Providing virtual well visits at a separate clinic, and then actually like staggering them, doing maybe a 2-month in-person visit, a virtual 4-month visit, but having a well site that actually can do those vaccines separately. Calling or sending, again, secured messages. I think that's one of the biggest pieces, is actually reaching out to families. I think that is so important right now. And using every patient contact anytime, if they're calling in for a sick visit or if they're doing a virtual visit for something else, making sure that we're recognizing that there is a potential for a missed opportunity. Making sure that we're administering all vaccines that you can at that time. And again, ideally receiving their immunizations at their medical home, but if needed, receiving them where we can get them in.
Great. Thank you so much, Cheryl. Those are wonderful, wonderful opportunities to keep that dialogue open. Mary, did you have any other suggestions regarding immunizations and getting folks to come in and maintain those visits?
No, I think Cheryl did a really nice job. You know, I think something that works well for us is, you know, we have a recall list. So we have a care coordinator going through that recall list and calling and reaching out to families. And I think that that makes a huge difference. I think that's very easy for families to ignore a text message, although some respond. But if they hear someone's voice and can get that reassurance, like Cheryl mentioned, that these are the things we're doing to keep your child safe, you know, this is how the process is going to work. I think that has been really beneficial in getting our families to come in.
Great. And along that same vein, we received several questions about what primary care practices are doing with respect to COVID-19 screening. And there was some great dialogue on open forum this week with some really great suggestions of processes that folks are doing so that when families arrive to their clinic with symptoms or just, you know, to be there for their routine care, what are some of those processes? So I thought we could open that up. I think, is Amanda Lee available to maybe answer that question?
Yeah, I'm here.
Hi.
So I'm primary care in Chicago at a federally qualified health center, and we're a very large network. We have about 34, now 35. We actually just acquired a practice this week. And so we probably, like all of you, have had a shifting approach as time goes on and as evidence changes and increases. And so for incoming calls, so we're seeing people, we've transitioned to telehealth and are still seeing patients in our health centers. And so for our incoming calls, we have a standard sort of symptom exposure travel screening for everyone that's calling into the clinic. And so as we sort of shifted our practice model from primarily in-person to telehealth, we established clinical practice guidelines by specialty. So for peds, adults, women's health, of who would be appropriate for what visit types, and which visits should be for telehealth sort of regardless, to have that initial screening with a provider. And we have sort of tended towards prioritizing telehealth, and mostly, again, they can be seen right away that day for sort of episodic concerns, because then they can have that more thorough assessment. So we do not have sort of embedded nurse care coordination. That would be beautiful to have that in our screening process, but we have a contact center and usually sort of front desk or receptionists that are making the appointments. So they have some general screening guidelines, and then depending on what is answered within that, then that will help them decide what appointment type is appropriate. And then additionally, so we are still taking walk-ins, and so for those that are walking in, there's signs on the door. They get everyone gets masked immediately and screened for symptoms. And if they are, again, that same travel screening, if they do screen positive, they'll be placed in an isolation room. So we have, at each health center, we have 2 rooms that are closest to the entrance that are empty at all times. So anyone that would screen positive for symptoms would be transported to that room. And then after the visit, it wouldn't be used again until it was cleaned by our facilities cleaning services. So kind of doing our best to catch people before they come into the clinic to make sure that they are appropriate essential in-person care. And then for those that are arriving to our health centers, and making sure that we're able to safely isolate them as best as we can in a community health setting. And we've also found that patients are they're concerned about being turned away. So they will, on the phone, they will answer negative to the sort of screening questions. And then when they arrive to the clinic, it's actually they had an exposure or they would like to be tested. So there's a lot of fear for patients as well that that we won't see them if they answer yes to certain questions. And so being able to sort of have that process happen at multiple points. So both when the appointment is scheduled on the phone and when they arrive, we found has been really critical to make sure that we're sort of capturing appropriately the information, but also that we're able to assure patients and families that we are here for them, but we're just making sure that it's the safest way possible for the patient and then for our staff as well.
Thank you, Amanda. I think we clearly are hearing that we have to take advantage of multiple touch points along this process to reinforce that message. And I'll just summarize a couple points from the chat, and we can move on to some questions regarding our acute care and critical care practitioners. Again, there's opportunities for families waiting in their cars until a room is ready. Again, the pre-screening before they're invited to the office, separating well child and sick visits. And also a member who said their hospital is offering a drive-through for vaccines even on specific scheduled days. So lots of different opportunities for opening up immunizations and making sure families feel comfortable. I wanted to give an opportunity too for our acute care members to have a chance to hear a little bit about what's happening in our critical care and acute care settings. I think one of the things that we've already started to talk about in children's hospitals is sort of how we're approaching our roles when we work in subspecialty practices and where we may be being deployed or utilized in new or different ways to meet the needs of not only children, but maybe other young adults and adults even if that's required. So several questions that came through from members were just how are hospitals approaching staffing of nurse practitioners and advanced practice providers? Are we being utilized in different ways? And to other points, is anybody running into being responsible for managing patients from an adult service in a children's ICU or pediatric ICU or in a children's hospital to meet the needs of those patients? So I wanted to see if Teresa might be available to answer this question. Teresa, our former past president of NAPNAP, thank you for joining us.
Hi, yeah. So for perspective, I work in the emergency department, and our cutoff right now is the 19th birthday. We've looked at going above that if it's something simple to try and help out. I work for a children's hospital in Chicago, and then we have outreach ERs that we also staff. So I am staffing an ER that is alongside an adult ER. So what I'm seeing in the adult world is extremely different and very, very scary. To put it into perspective, there was a JAMA article, I think, that came out today. There have only been 8 reported deaths in children under the age of 14 from COVID, as opposed to the 169 deaths that we've seen from the flu. So what we're seeing in the emergency department now is a lot of what we've talked about, that inflammatory disease and the delay in care. And so the virtual ill visits, I think, are great in some respects, but I think we're seeing a lot more kids with antibiotics and that coming in later. And then we've been trying to kind of help out in the ER, seeing some of the older people with simple things like ankles, wrists, things that we can kind of manage to try and take off the plate for our adult counterparts as they're dealing with what I'm looking at is much, much more sick people than they really have in the past. The amount of arrests that I've seen on the adult side, comparatively speaking, in the past to now is just so grossly different. From our perspective, from our hospital, we've done 3,500 tests in children. 10% of them are coming up positive, 331 out of the 3,500 that we've done. But out of that, only 57 of those kids have been hospitalized. So we're looking at about 2% total tested kids getting hospitalized, or about 17% of those that are testing positive actually needing hospitalization. So I think it's not even so much that my department is seeing different age groups and stuff like that. I know we've been dispersed throughout the hospital related to the lower volume. So we may not be necessarily working in the department that we normally work in, depending on where the volumes are that day. We have accepted higher age groups in the emergency department for us, as well as in our hospital, to be able to accommodate. The other thing I know my hospital did was we took over the pediatric patients for multiple hospitals in the city of Chicago so that they could open those beds for adult patients. So a way to kind of stay within our wheelhouse, but yet still open up the ability for people who normally take care of adults to be able to do that more effectively. And all this is happening while, I think people have mentioned this, there have been pay cuts and furloughs and other things like that that have happened across the nation, and I know in our institution as well. So it's kind of fascinating to see something where we're in a crisis, we're needed more than ever, but at the same time, we're dealing with less revenue and such in order to deal with this. So, I mean, we know children's hospitals only function because of philanthropy to begin with. But if we don't look at what's happening in DC, thank you, Dave, for that update, we're not going to survive.
Thank you, T. Thank you for sharing that. I think it's a really complex environment, to your point. I think all of us feel like we're capable and ready and willing to go and do what we can do, but we know we're practicing in the environments where it's constantly changing, where that need might be. Again, I would, since I do see some comments in the chat and additional questions we've received from members about caring for young adults, and I do want to refer our members to our official statement on this, as it addresses not only our position statement on age parameters, but also taking into account state practice acts, taking into account the need of what hospitals are needing, taking into account safe harbor protections for pediatric nurse practitioners, as well as ensuring that we transition care to an adult provider and working collaboratively with our colleagues to the best that we can in our individual care settings.
Hey, Raji, it's Pat. Can I just throw one idea in? I think one of the things that we want to do at NYU is we want to meet with our senior director of advanced practice before the surge that might happen, to really relook at what happened and what might happen moving forward, because I think a lot of the pediatric NPs were not comfortable with being told, well, now you can care for patients up to the age of 32. So, these are the things that we need to, when we are in a period where we can have these conversations. I recommend to others around the country that if you're experiencing anything similar to what we did, is to have conversations when you can, before you start getting into more of a crisis mode again.
That's a great point, Pat. And again, we're out of that initial sort of phase of everything happening. We know that we can anticipate potentially things to happen again in the fall. So that's a great point to take advantage of having those conversations now so we can learn from it. Again, the other question we got from members was this new inflammatory Kawasaki, like findings that we're seeing. So something that I think we're going to follow really, really carefully and very closely. It's been so fascinating, as we said, that generally speaking, children haven't been directly impacted by COVID, but we've seen a lot of indirect impact. But this virus is just so fascinating, and how it's behaving and how it may impact children. So I think we're going to continue to follow cases around the country, and certainly encourage our members to keep letting us know what they're seeing in the presentation of these children and how they're responding to treatment. So lastly, I wanted to make sure we had some time to just talk about some policy related questions. As you can imagine, the majority of questions came through were about telehealth. And we've had such a wonderful opportunity to learn about how this platform can be beneficial in acute care and primary care settings. And again, from a policy standpoint, trying to better understand how some of the restrictions that have been loosened with respect to telehealth practice have helped us, and whether or not that may or may not continue. One thing I will say that I think that a lot of members have told me about is this sense that now telehealth has been there, it's completely expanded at a time like this, and I think it will very much become a part of our practice going forward, one way or the other, however we decide to build it or continue it into our care. And so it's a skill set and something that we have to continue to build and follow. But one of the questions that we got from a few members was related to, with the policy changes we've seen behind telehealth, will we expect this to become more widely available and also open permanently, potentially, again, we don't know, for use across state lines? And we know that there have been a lot of different state approaches to the use of telehealth. So I wanted to call on our fantastic telehealth expert, Kelly Garber, if she's still available, to maybe help provide a response to her thoughts on the use of telehealth across state lines.
Hey, thanks, Raji. I'd be happy to. Certainly, I'm not happy about what caused the increase in telehealth across the country, but as someone who's passionate about telehealth care, and I've been doing it for about 6 years now, it's exciting to me to sit on these calls and listen to how many of you, whether it's acute care or ER or primary care, are employing telehealth in your regular practices. And I think you'll find, apart from the fact that you've been thrust into it without a lot of planning or preparation, over time, when you have the chance to pause and think it through and kind of look at the whole thing from a broader perspective, I think you'll find that it can fit very nicely into our practice, and it will likely continue to be just part of how we do care going forward. So having said that, with regard to the cross-state licensing, this is something that I definitely get a lot of questions about. And prior to COVID-19, I just have to set the landscape for that. You know, it's really been expected that you're licensed in the state where the patient is located. And that's still really what's expected. Now, the CMS modified the requirement for the provider to be licensed where the patient is located, but that's pertaining to billing. It doesn't override state laws. And many states have telehealth laws, or there may even be laws on the books that specifically pertain to cross-state licensing. But many telehealth laws require that the provider giving the care is licensed in the state where their patient is located. And so it's important to note, again, I'll just repeat that, you want to know what's happening at the federal level and with CMS regulations and guidelines, but you also have to know what's happening in your specific state in terms of laws and regulations. As a result of COVID-19, many states have allowed cross-state practice, but some are very specific with that allowance. In other words, they may allow a cross-state practice from the very neighboring states, and that may be only through an executive order that's temporary for COVID-19. It's also important to know not only what the telehealth laws say, but what's in the Nurse Practice Act for those states where the patients are located. And so if you're used to practicing in a state with full scope of practice and your patient lives across state lines and that state has restrictive practice, you're going to need to make sure that you are compliant with what the regulations and laws are for APRN practice in that state. So if they require a collaborative agreement in that state, but not the state where you normally reside and practice, you'll want to make sure that you have that in place and that you include telehealth in that. It's also really important to make sure that when you're looking at cross-state licensure, you'll hear things about the nurse, the ENLC, the Enhanced Nurse Licensure Compact. And that allows nurses to practice across state lines, but it does not extend to APRN practice. There is an APRN compact, but it won't be enacted until there are at least 10 states participating, and currently there are only 3. Now, there are a lot of other cross-state licensing compacts for physicians, behavioral health, and many others. And recently, the Federal Office of Rural Health Policy provided a grant, awarded a grant to look into extending more liberties for cross-state licensing. And so the recipients of the grant will work to, with professional organizations, state boards, to extend cross-state practice. However, everything I've read about it uses the term clinicians. The awardees of the grant were the Association of State and Provincial Psychology Boards and the Federation of State Medical Boards. So I suspect that the focus is going to be on the medical licensure compact, not on, you know, other healthcare professions. So that's a long-winded answer to the question. The bottom line is, right now you must make sure that you know your state's law and the states that the patients are in that you're providing care to. Because even if they're part of your regular practice, but they reside across state lines and you're now connecting them to them through virtual technology, you'll want to be sure that you're compliant with both states' regulations and laws.
Thank you, Kelly. Thank you so much. And again, I think another opportunity for us to continue to document the benefits of telehealth for different patient populations and what we're learning from this, and really show the outcomes of care as provided by it. I again want to, I know there's a lot more time we could always spend just talking about telehealth, so I do refer members to your Facebook Live presentation, as well as the presentation you gave on our Child Health Policy Learning Collaborative call, which Michelle just posted the link for some additional questions and answers on that. I do want to be mindful of the time and maybe just ask one other quick question. I think we could keep going. There's so many important things to talk about on this, but I am so grateful we had this opportunity to start to look at some of these things from a lot of different lenses. But one other question, and really more of a comment that came through prior to the town hall, is what is NAPNAP's role in advocating for improved public health infrastructure? We're learning so much about prevention efforts and screening, and how do we support children in this process? And certainly in our work and our strategic planning, this came through a lot, thinking about social influencers of health, food security, housing, community safety, all of the things that we know impact children's health. And so it's just something I think for us to think about, is that NAPNAP has a role not only in all the things we've talked about, but more globally thinking about the space that we can enter now as it relates to public health, and supporting and funding the structures and resources that keep our community safe, and certainly advocate for things like immunization and access to care, both physical and mental health care for children, to support their overall health and well-being. So I just wanted to say that was something that a few members had written in about.